because he's going to give us the debate. Gregg Stone needs no introduction, really. He's world renowned, and he's the director of academic affairs at Mount Sinai Health System. And what he's going to do, he's professor of medicine and population health science, and he's going to say that PCI is treatment of choice for most patients, especially in those PCI versus CABG versus optimal medical therapy in patients with LV dysfunction and multivessel disease. Dr. Stone. I'll tell you. You want to know the time? How much time you have for each one?
No, I'll be 10 minutes.
Perfect.
So Roxanne, I win every year, so it's not just this year. So we're actually we're doing something a little different because we're debating PCI versus CABG versus medical therapy in patients with LV dysfunction, which none of those patients had, and that makes it a little bit more challenging. And I'm going to take the stance that PCI is the treatment of choice for most patients. These are my relevant disclosures. So first of all, does revascularization help in patients with LV dysfunction? Well, the only contemporary data we really have is from the ischemia trial, which was basically medical therapy versus revascularization with either PCI or CABG in stable coronary disease. And as you know, there was no difference in mortality, CV death or MI, or the primary composite endpoint. But the one subgroup that, even though in this trials, patients with severe LV dysfunction were excluded, patients with moderate LV dysfunction were included. And the one subgroup that really benefited were patients with moderate LV dysfunction, EFs of 35 to 45%, or those with prior heart failure. So yes, revascularization does help these patients. And then we've got the STITCH trial. This is the best single, most adequately powered trial of any sort of revascularization, and this is with CABG in patients with ejection fractions of less than or equal to 35%, multivessel disease, randomized to surgery versus medical therapy, and 1,212 randomized patients. It took 10 years to become positive, okay, but it was positive. And there was a pretty substantial reduction. The number needed to treat to prevent a death was 14 patients, so significant reduction with surgery. Now, most people don't want surgery, okay? Most people with extensive coronary disease, whether it's LV dysfunction or not, want PCI. And why? Because this is the patient 3 hours after CABG, this is the patient 3 hours after PCI. That doesn't change, okay? So the principle of autonomy dictates that this choice that patients have must be respected. So the real question for this debate, and I know that Mario would agree with me, is that are the advantages of CABG in patients with LV dysfunction so profound that we should strongly recommend that patients go through the considerable discomfort and prolonged recovery that surgery entails? So when you ask what patients care about, that's different than what doctors care about. Doctors care about survival. That's pretty much all they care about, survival. Stroke, MI may be half as important as survival, and other outcomes much less important. But patients care about stroke and large MI at least as much as mortality. Everything else less important. Patients want to live and they want to feel good. And in fact, if you do other surveys and you ask patients if CABG is going to have a 3% mortality, what would have mortality of PCI have to be before you would start choosing CABG over PCI? And the answer was about a 6% mortality. That's how much they favor the lesser invasive characteristics of PCI. They would take a double mortality, and you've got to respect the wishes of patients. So think about that as we look at the data. So what data do we have about PCI for LV dysfunction? Well, we have one randomized trial, and it was the most recent revived BESIS trial, and it was negative. Now, this was 700 patients with ischemic cardiomyopathy randomized to PCI versus medical therapy, dead-on negative trial, okay? 5-year follow-up, median 41-month follow-up, absolutely negative, okay? But first of all, this was half the size of STITCHES, and they didn't have 10-year follow-up. STITCHES was also negative at 5 years. And more importantly, these patients were very different. These patients do not have heart failure. These patients aren't even having angina. They're tolerating their LV dysfunction just fine, okay? Very different from STITCHES where patients had heart failure and angina. And in fact, if you start looking at large registries of patients with heart failure and angina because of LV dysfunction, such as the New York State database of LV dysfunction, EF less than 35%, now you see similar mortality with everolimus-eluting stents and bypass surgery. Yes, higher rates of MI and revascularization, after PCI, but lower rates of stroke after PCI. So overall, it's a pretty good trade-off, and patients get the lesser invasive therapy. Now, we also have data in left main disease, 4 randomized trials of drug-eluting stents versus CABG in left main disease. And of course, you know this meta-analysis from the TIMI study group. There's no difference in mortality at 5 or 10 years. So what about LV dysfunction? Well, here's the data. No difference in mortality, left main and multivessel disease with LV dysfunction in these patients, PCI versus CABG. And then finally, remember that there's no doubt that stroke, which remember patients care about at least as much, if not more, is increased after bypass surgery compared to PCI. This was individual patient data analysis we published, 11,518 patients, multivessel or left main disease. Come on, there's about a 1% increase in stroke. So patients have to know that. Now, more than any of these outcomes, patients want to live longer and they want to feel better. That's what they really care about. So quality of life encapsulates all these non-fatal outcomes. And of course, why do patients want to have PCI? Because it's reflected in the data that we have. We have 2 large-scale quality of life outcome studies, one in the Syntax trial, 1,800 patients with triple vessel left main disease. There's no overall long-term differences in quality of life, but look at the short-term physical disparities. Patients feel much better after PCI, and it takes them about 6 to 12 months before they're feeling similarly after CABG. We did the same thing in Excel. Equally, both procedures are great at relieving angina and otherwise improving quality of life, but that first 6 to 12 months, there's a longer recovery period after CABG. So you really want to reserve CABG for the patients that absolutely need it. And then finally, not all patients with LV dysfunction can even undergo surgery. This is the Optimum registry of PCI in 726 patients turned down for CABG at 21 United States hospitals. The mean ejection fraction here was 42.6%. And if you look at the reason for surgical ineligibility here, you can see severe LV dysfunction was about 17%, frailty, immobility, advanced age, prior stroke, et cetera, et cetera. Now, if you look at some of these characteristics, these patients had really complex coronary disease. They had median Syntax scores, mean of 32.4. A quarter of them needed hemodynamic support during the procedure. You can see large percentages of CTO, left main PCI, atherectomy, et cetera. So how did they do? These are surgical turn-down patients. That's how you got in this registry. Well, these are sick patients. The overall 30-day mortality was 5.6%. That's pretty much exactly what the risk scores would have predicted, except the surgeons thought that if they operated on these patients, they would have had a 10% 30-day mortality. So not too bad. And most importantly, these really high-risk patients, a lot of whom had LV dysfunction, felt substantially better after PCI. Their angina was relieved, their quality of life improved, their heart failure scores improved, and if you look at their angina frequency, again, much, much less. So they obviously improved their quality of life. So if I was going to conclude, PCI versus CABG versus medical therapy in patients with LV dysfunction, patients want to live a long, healthy life. Unfortunately, left ventricular dysfunction reduces longevity, increases stroke, and impairs quality of life. So we're up against it with these patients. Revascularization extends survival in patients with left ventricular dysfunction. In patients with LV dysfunction, CABG has been shown to reduce mortality. The effects of PCI are likely similar, but we don't have as much randomized data. Now, there is a big ongoing, the Stitches 2 and 3 trial that are ongoing right now that is comparing PCI versus CABG, but it's going to be a number of years before those trials are done in patients with LV dysfunction. Regardless, stroke rates are increased with bypass surgery compared with PCI in all patients, whether or not they have LV dysfunction. And that is, again, the second most, if not the most important outcome for a lot of patients. PCI is preferred by almost all patients because it's a lesser invasive procedure with markedly better early quality of life and similar late quality of life. PCI improves quality of life even if bypass surgery is not possible. So PCI in patients with LV dysfunction is evidence-based and it's common sense. So for those of you who are making heart team decisions, pay attention and listen to your patients. PCI should be the procedure of choice for most patients with LV dysfunction. Thank you.
Thank you.